Just wanted to give a quick health update slash describing some of the medications I'm on. Feel like it's helpful for people to understand that, both that are in the community and things that they may want to look into. It's not advice, but it is foundational for me. And the whole reason I'm still alive is because of knowledge in the community. So things that you may want to look into, see how they could potentially benefit you pending your symptoms, and personal situation. But currently, medications I'm taking, I've got famotidine, which is an H2 blocker. Originally, I was on it after switching from a PPI for acid reflux. But PPIs are bad. I've been on them for forever. And shortly after the pandemic started, I switched to famotidine, which, being an H2 blocker, has a secondary benefit for me, which I have mast cell activation syndrome, MCAS, and an H2 blocker is valuable there. So it helps with my acid reflux and that. I also take low-dose lithium. Low-dose lithium is potentially good as an antiviral. I take metformin. Metformin, traditionally used for diabetics. I'm not diabetic, but it does have antiviral properties, so that's why I take that. So that's off-label. The low-dose lithium is available, in most pharmacies. Metformin is widely available, and famotidine is as well. Get into the antiretrovirals that I'm on. So I take Maraviroc, however you want to pronounce it, currently twice a day at 300 milligrams. Now, I'm going to be stopping that because I am hopefully starting very soon Ensitrelvir, Zycova. Zycova is the brand name. So Zycova is also it's a protease inhibitor, and it specifically targets the virus, SARS-CoV-2. It stops it from replicating, which is a big issue for me and many people who have long COVID and acute COVID. It's traditionally prescribed for people with acute COVID to prevent symptoms, to stop the virus from replicating. So that's obviously, in theory, if you have viral replication going on, why it's useful in long COVID. I also currently take Truvada, which I stopped yesterday because now I'm starting Descovy. Both very similar drugs. They use a different secondary what do I even want to say, ingredient? It's brain fog at its best. And I'm always I'm a proponent of language, so I hate when I fall into that. So brain damage, it's not brain fog. I just physically don't have the words sometimes. Mentally, I should say, don't have the words. But the clear differentiator there is when people are like, oh, fatigue. No, fatigue is what you have pre-chronic illness. Like, you're tired, you worked a long weekend, you pulled a night shift, you went out and partied, and you're dehydrated, blah, 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 yada, yada. That's fatigue. Had a hard workout, whatever. But this is debilitating fatigue coming from cellular exhaustion. Like, your cells physically are not, acting in the way that they're intended to. So it's not like you're just tired. It's your body does not have the energy and isn't functioning in the way that it should. So anyway, that is fatigue and brain damage, not brain fog. So anyway, the different prescription in this is the tenofovir alphanidamide. I don't know. I hate these names. So that second ingredient there is different in Descovy. And essentially two things: better efficacy, and more importantly, because I don't know that the efficacy difference is all that important for me, because it's off-label anyway. It's around, I think, a 10% difference in efficacy, but it is less harsh on your kidneys. So that's why I'm switching to that. Today's my first pill of that. Then I take low-dose naltrexone, and I take the highest dose of low-dose naltrexone, which is 6 milligrams. So I take a 4.5 and a 1.5. The reason I do that instead of one pill, because you have to get it compounded by a compounding pharmacy anyway, is, at some point in the past, I, started with a lower dose and I titrated up. And for a while, I tried scaling back and seeing how I did, and I definitely need the full dose. So anyway, it's just nice to have that flexibility. Sometimes, because I don't want to build up a tolerance too, I might go a week and just do 4.5. And then sometimes I might even do a couple days at just 1.5, like 2 or 3 days in a row. But for all intents and purposes, I take 6 milligrams a day. So those are the prescription medications that I take currently. In addition to sometimes thymosin alpha-1, which is an injectable peptide that helps my thymus. Looks like I've got some droopy eyelid shit going on here today. But helps with T cell replenishment, because Jesus, it's really bad. My T cells are, they're there, but they're depleted, as is most of my immune system. So anyway, I just wanted to share that. There's a lot of people on a lot of other things, some more, some similar and just different. But I feel like it's good for me to document this stuff, for myself, for history. But yeah, I'm on a couple medications with antiviral properties, a couple medications that are actual antiretrovirals. The low-dose naltrexone is off-label. It's usually used to get people off heroin or OxyContin, because it literally blocks pain receptors. And I didn't mention that. So the Maraviroc, Truvada, and Descovy are all traditionally used for HIV/AIDS patients, either as PrEP or as treatment, and combination therapy again. So this isn't a singular thing, and I'm pretty confident, as are many of the people I talk with, that long COVID, it's an umbrella condition that may have one source that's causing everything. It might be a couple different sources, but ultimately, taking a couple different medications is what it's going to take. It's not going to come from one, in my opinion. Not just antivirals, antiretrovirals, monoclonal antibodies. And a lot of people feel pretty strongly, if this ensitrelvir Zycova works well for me, for blocking the replication that's going on, my next thing is looking at monoclonal antibodies, and there's not really too many available, unfortunately, at least in the States. So it's going to require some other things. A lot of people do EBO, which is basically just filtering your blood, literally running it through a centrifuge, using ozone, and some cases UV, filtering it out, trying to purify it, remove the virus that way, and any other contaminants, which I don't know. I'm not really I don't like blood, so I'm not not really putting my foot forward there, but I also can't be like this any longer. The only thing that's worse than that is getting worse. So I've got those two things, is, I don't want to be like this anymore. The only thing that's more powerful than that for me is getting worse. I don't want to get worse. So those are my big considerations whenever I try something new. It's I'm doing it because obviously, I don't think I'm ever going to be who I was. But I do think that everything I've done up until this point has kept me from getting worse. And it would be great to do a thing or two that actually help me improve a tad. If I improve a tad and I'm able to maintain that, that would be fantastic. But my biggest fear is getting worse. And you never know. That's one of the scariest things. You know, you've got cancer, you go and get treatment. You know, it either works or it doesn't. Sadly, if it doesn't, you usually end up dying, right? You know, there's a lot of different illnesses where that's known. You know, there's historical treatment that either works or it doesn't work. And then if it doesn't work and you still have time and, more importantly, money or accessibility, you try the next thing as long as you're alive. And that's what people with long COVID are doing, except there is no history. There is no known data. So you're using things from other fields, from other illnesses that are relatable, and you're trying to make connections and trying those and seeing if they work. So you don't have like a roadmap. It's just the Wild West. And the strongest similarity is, as long as you're still alive, you keep trying the next thing. And you can see how you very quickly run out of money, because where the issue is with something like cancer, it's very expensive and insurance ultimately stops trying to pay for it, and you can, you know, have significant insurance bills. I will say, brutally honest, if I had cancer and I had a big insurance bill, I don't have money to pay it. Oh well, I don't feel bad about that. You know, fuck you. That's our country's broken. My life is more important and living than the broken corruption that caused that. The problem with chronic illness and long COVID patients is almost all of our treatment isn't covered at all by insurance, so it comes out of your pocket. So you don't have that contingency plan of like, oh, I'm going to get this, and if I can't, you know, pay it over time, oh well, fuck it. You know, like, maybe if you're lucky, you can set up a payment plan with these people. But, you know, for the most part, a lot of the treatment is out of pocket. So what that means is you very fucking quickly go broke. You go through all your savings, you go through all your retirement, you go through, you know, selling shit just to have enough money to try the next thing to stay alive. So anyway, you know, this was not a super exciting video for anyone that cares to watch, but you know, I think it's meaningful. I think for people to understand better what a day in the life is like, and this is just obviously the pills I take, and not even the pills, this is the medications. You know, like a lot of other videos where I'm talking about all the pills. So there's pills, there's enzymes, there's supplements, blah, blah, blah. You know, here's another one. I take these things. These are cellular energy, mitochondria enhancing. So just a small part of the struggle every day. And some of the craziness of what we deal with. I mean, literally one of those drugs I'm taking for the reason it's supposed to be taken. One. All the rest off-label in some capacity. So I'm very fortunate to, you know, have connected with many people in the community that are, you know, they document, they research like myself. You know, I'm very fortunate to have a good medical team, to have a great primary care doctor. You know, if you're watching this, that's vital, because you need someone who's going to be, you know, open to prescribing you the things that you need. Now that doesn't mean just blindly doing it, you know, it means ethically doing it. It means, in my case, you know, I provide cited peer-reviewed papers. You know, I provide studies, I provide links to the latest research, I provide articles that are substantial. And, you know, those are the things ultimately the doctors follow anyway. It's just typically they follow them, you know, a decade, 2 decades past when they're, you know, initially published. This is, you know, bleeding edge shit that's like happening now. So typically doctors aren't finding out about that till way distant future. But if you have a good doctor and, you know, they want to uphold their oath and they understand science, which, I mean, fuck, every doctor better understand science, but clearly they don't. So anyway, you know, being able to refer to resources like that is really valuable. So hope you found something out of this. You know, I also just want to end by saying I do take a lot of other things like this MitoQ, and it's, what is it, for cell vitality, but also liver. I've got another thing here, Quicksilver Scientific Push Catch, which is a liver detox. Got some shit up here. This is all Quicksilver Scientific, by the way. Dr. Shade's Kidney Care. Reason being, like, you know, I don't want to be on all these medications. Medications aren't great. They're typically harsh on your liver and kidneys because that's what filters them through. So I take these things to help give my system the chance it needs. So anyway, longer video. Thanks for watching. Hope you're well. Let me know in the comments, you know, any questions, any things that you think are beneficial, any add-ons. But I just wish you, you know, all the best health and keep pushing forward. Thanks.